Hi, I'm Dr. Tariq, consultant internal medicine, American board, currently working in UAE. Today, I'm going to present a very important topic, that is gestational diabetes or diabetes in pregnancy. There are different kinds of diabetes in pregnancy. Some people have got type 1 diabetes. That's another topic. Some people have already diabetes and their diabetes gets worse during the pregnancy. But what I'm talking about is today is the gestational diabetes or the diabetes that happens in pregnancy. Patient is okay before pregnancy, no diabetes, but then he starts showing up as a diabetic patient. We'll discuss about it. It affects about 5 in every 100 patients, this gestational diabetes. It's one of the secrets of nature how the people develop this diabetes. So I'm going to explain it to you. Now, the story of gestational diabetes lies in the evolution. See, the baby is growing in mother's tummy. No matter what is happening outside, this baby needs nutrition. And this is a very selfish baby. The babies act like a parasite. They want their nutrition no matter what. So, this is what happens. See, up till the 24th week of pregnancy, the baby size is very small. And the amount of nutrition required for this baby is it hardly matters. It can be put up. Now, thousands of years ago, millions of years, as we take all the human beings or the primates and other species, mammalians, the food was not available every time. There were periods of time when there was no food available for days. And in a normal person, the glucose is maintained between 50 and 150 if the person does not have diabetes. Now, when these patients are starving, the people are not having food, the sugar level drops to 50, the bare minimal to maintain the life. That's okay till 24th week. But after 24th week, if the sugar levels are low, around 50, they're not enough to sustain the life of this baby. So the nature came up with a very smart solution to that. This placenta starts releasing a hormone called human placental lactogen. This human placental lactogen counteracts the effects of insulin and causes insulin resistance. And as a consequence of that, the sugar levels, they go up from the basic sugar levels during starvation goes up from 50 to about 100. So no matter how much the mother is starving, the baby will always get a sugar level of 100 milligram per deciliter blood supply. And this will cause the baby to grow, enough for the baby to grow. And it may cause mother to lose weight, melt her muscles, her fats, but this sugar will reach the baby. Oh, this baby will maintain its growth. Now, what happens is some people have genetically predisposed to diabetes. They have already got insulin resistance, but they don't know about it. And by the 24th of week, the placental HPL, human placental lactogen secretion, starts reaching higher and higher and higher, and it reaches to its maximum at the 36 weeks. And this, in the patient who is already insulin resistance, will result in a gestational diabetes. So from the 24th week of pregnancy till the 36th week of pregnancy, these patients will show up as diabetes. Their blood sugar levels will be high, they will be over diabetic patients just because of this human placental lactogen. And once the baby is delivered, the placenta comes out and the insulin resistance drops to the baseline levels, and patient again becomes normoglycemic, no sugar, sugar is gone. And it will continue maybe 10 years, 5 years, 20 years, depends upon how much insulin resistance was there to begin with. But eventually, these patients will develop diabetes. Precautions are not taken in the long run. Now, this thing can have bad effects on the baby. You see, if you're not controlling this sugar and this HPL level goes to the sky, mother has a high sugar level 200, 300 because of that. All this sugar goes to the baby through the placenta. And baby has got its own pancreas, which is fully functioning normal pancreas. So how much, no matter how much sugar you give this baby, his pancreas will start making more and more and more insulin. And as a consequence of that, the more sugar, the more insulin, and the baby starts getting healthier and healthier and bigger and bigger. That's the reason for the big babies being born. And he may achieve a weight which is so high that he cannot be delivered normally. And when he cannot be delivered normally, you may have to do a cesarean section for the delivery of the baby. Or there may be complications of the delivery of this large baby. One of them is shoulder dystocia. And once the baby is born and he's used to the high sugars, he's getting not that high sugars with the feed, he may start getting jittery and fits and hypoglycemic episodes. It can be dangerous and fatal. And on the other hand, he may be having very high red blood cell count because of the high insulin level and higher growth. And he may be born polycythemic, which may end up in having a jaundice in the beginning of the pregnancy, a physiological jaundice, but exaggerate. So these are basically the complications of this uncontrolled diabetes. That's why we need to have this mother sugar controlled, not more than 100, not less than 100, fasting not more than 120, not less than 120 after eating. So we have a balance of between the hyperglycemia and hypoglycemia, a sustained normal amount of sugar reaching the baby, so he does not have complications. And this translates into an HbA1c level of 6 in the mother, which we check every 3 months. As I mentioned, after 24th week of pregnancy, these people with gestational diabetes, mothers, they start showing signs of high sugars. They will have excessive thirst. They will go to the bathroom very frequently for passing the urine. Their mouth may be dry. There will be some blurred vision and some malaise. And there is irritation on the private parts because of high sugar causing these opportunistic fungal infections. And as I showed you already, this is the insulin requirement during pregnancy due to the HPL secretion from the placenta. Now, for this reason, there is a screening process for the patients pregnant ladies, because sometimes it does not get detected. So for this purpose, there are two types of tests. One is a one-step test and one is a two-step test. One-step test is any patient who comes, no fasting requirement, just they give him 50 grams of glucose and then they check the sugar after 1 hour. If the sugar is above 140, as I told you, the insulin always normal person 50, 150, it does not go beyond that. But if it is 140, then there is the second test done. The patient who have got less than 140 is nothing to worry about, just fine. The one who have got more than 140, then they are sent for the two-step test in which they are given 100 grams of glucose and the sugar is checked fasting and 1 and 2 and 3 hours after taking this 100 gram of glucose. And the result is considered positive if the fasting sugar levels are more than 105, after 1 hour above 180, after 2 hours above 155, and after 3 hours above 140. So these are the threshold levels at which we decide the board whether the patient has got diabetes or not. Now again, there are two kinds of gestational diabetes. One kind which can be controlled with the diet only, and the one which requires treatment. The one which can be controlled with the diet, they are usually given foods that are low in glycemic index. Glycemic index is nothing, basically it's the rate at which the sugar is released from a particular food. So as I'm showing you in this chart, these are different foods which have got a glycemic index below 55. So any food which has got a glycemic index below 55 is good for the pregnant ladies. They can distribute it over time, so they don't take it in bulk, small quantities of snacks all over the day with these low glycemic index foods. and it will keep the sugars controlled. You can see some foods are very low, like 14 glycemic index of plain yogurt, and a chocolate bar with a glycemic index of 49, and a popcorn with 55. So you have to juggle between a combination of very low and less than 50 glycemic index foods and continue taking them. And this is the required, as you see, fasting should be less than 100, and after meal it should be less than 120. That's the ideal. And A1C 6%. That's the ideal, and you can always check it by the antenatal sonography, see if it's going on fine with the size of the baby and other measurements which are done at the antenatal examination. Now, as far as the sugar that needs to be controlled with the insulin, before it was only insulin. Now it is a combination of insulin and glucophage also, because some of the patients, they were using metformin for the polycystic ovaries, and they got pregnant, and then they continued the metformin, and the results were good. There was no fetal damage. So that's why after that the glucophage metformin also became part of the management. Now there's one more thing. The newer insulins like Lantus and Seba and the other new insulins in the market, they are not proven to be safe in the pregnancy. I mean, there is no data up till now. Maybe it will come later. So that's the reason we're using plain insulins for the management, or the earlier insulin, mixed insulins, which are prepared from the plain human insulin. Now the thing is, this usually the insulin. I will not give you specific medication and a treatment, but I'll just give you a guideline. The thing is, insulin is given in depending upon how bad or how good your diabetes is, gestational diabetes is. Insulin is either given regular insulin before each meal, and moderate mixed type of insulin, moderate acting insulin at night, or you can use regular insulin before breakfast and lunch, and then a mixed insulin at the dinner time. Or you can use mixed insulin in the morning and mixed insulin at night. Or you can use insulin combination with metformin. All are acceptable, and it all depends on the results which you achieve with this. If HbA1c is 6, sugars are less than 120 after meals, anything works. Now, I'll give you a formula which you can discuss with your doctor that will give you a good level of control. See, the Novo mix that you take at night deals with the sugar which you take after the dinner and the fasting blood sugar. And the insulin Novo mix, any insulin mix, any insulin that you take before breakfast, mixed insulin, will deal with the sugar levels 2 hours after breakfast and 2 hours after lunch. Or any regular insulin that you take before meals will be related to the insulin to the 2 hours after the meal. So if you take regular insulin before breakfast, it will directly translate into the sugar levels 2 hours after the breakfast. Now it's clear. Now, say for example, you want a fasting level of 100 and post meal level of 120. So say for example, your sugar becomes after meals 140, 160. So for every 10 milligram of sugar, 10 milligram per deciliter sugar above your required desired level, you have to add 1 unit of insulin. And for every 10 milligram below that level, required desired level, you have to decrease 1 unit of insulin. And which one you will decrease? If your fasting is low, you have to take care of the night, the intermediate acting or the mixed insulin that you took at the night. It will deal with the sugar in the morning or at the midnight. Whereas the sugar after breakfast and after lunch will depend upon the mixed insulin which you took before your breakfast. So this is how, if your fasting will deal with night, and your post breakfast will deal with the morning insulin that you took. For the mixed, it is 2, For the regular, it's only one meal that you have taken. So this is how you can discuss with your doctor and make a plan about the control of your sugars. Thank you very much.